for coming. Debbie, can you call the roll for us, please?
Sure. Let me make sure. Can online hear us? No. Scott Stevens, can you hear us?
Yes, I can.
So Courtney Terwilliger,
I'm here.
Lee Oliver,
Here.
Scott Stevens online, Jeff Adams. He's here. Pete Quinones. Sam Polk.
Here.
Blake Thompson. Dwayne Montgomery. Alan Owens.
Here.
Brian Hendricks.
Here.
Vic Dravi.
He's here.
Huey Atkins.
Here.
And Jen Atkins.
Present. We have a quorum. Thank y'all for coming. You were sent. I think we got a thing here that we need to, we've got several new members and we got several, well, yeah. So what I'm gonna do is we'll pick on the new folks first and just introduce yourself and tell you a little bit about yourself. And then I think we'll go around the table and because y'all know we're gonna start picking up. Just go around the room that way, Brian.
So my name is Brian Hendricks. I'm the Assistant Director at Bolton County. Been doing this since '95 and went to Leadership Board, and Dick picked on me and asked me if I wanted to, I was interested in this venture, and I said, sure. So I don't know if that was a smart thing or not. So we'll see.
It's the only guy I could get to do it. Nobody else would.
Thank you.
Tom, you want to introduce yourself?
Tom Snyder, retired. Started this in 1968. Figured it was about time to retire about 10 years ago.
When I started as an EMS director generations ago, when I had a problem, Tom was the guy I called and said what to do. So he has helped me throughout my career. Tom.
Jim Atkins, I started in 1969 working for him, and I just sold South Star Ambulance to Gold Cross. So I'm a retired dinosaur.
Alan Owens, well, compared to these guys, today must be my first day, so I started in '99 on the EMS chief of Tift County Fire Rescue. That's about it.
I'm Scott Roberts with Fayette County EMS Director and Assistant Chief of EMS Administration. I've been there for over 30 years now, and I actually just took over that position from Steve Ford, who retired many years ago.
And so Scott will be taking my place on the committee. I was elected to Region 4 Council Chair, so I'm moving out of the RTAC and all that. Scott will be our RTAC Chair and EMS Subcommittee Rep, effective now.
Big nobody, just glad to be here.
Huey Atkins with National EMS, and been doing this since '76.
Lee Oliver, I'm the Region 5 rep from Central Georgia. And I used to call Tom in the early 80s too, so still call Tom, just hadn't seen him in a while, so glad you're here.
So one, thank y'all. It's gonna be a little bit difficult for the ones online, but as they come back to the meetings, we'll talk to them. I want to give a few minutes to talk about essentially what our charge is and what we try to do. When the Trauma Commission first got started, a lot of the members really weren't exactly sure about what to do with EMS. There was some confusion about, how EMS should request funds and get information back and forth between the Trauma Commission and the EMS community. And Dr. Ashley set up with this committee so that statewide, there will be two things. One, we could send information and desires to the Trauma Commission, but the other, very, very important role for you is to take this information back to your local EMS agencies. Georgia is a huge state, very, very diverse population as far as urban versus rural. What works in Atlanta might not work in Hayhire, Georgia, or Pearson, Georgia. Vic and I were talking about Pearson this morning. You go to the subway station at Pearson, you don't have to wait at all. You get right on. So it's our goal for you to be that back and forth between the Trauma Commission and your local EMS council. So most of you are some of you have been appointed by EMS councils. Some of you are appointed by elected officials. And so that once you're appointed by elected officials to the Georgia Trauma Commission, and Dr. Ashley puts you on certain committees, and Jim is on the Trauma Commission and is appointed to this committee. Regina Medeiros is also on the Trauma Commission as a member of this committee. We try as best we can. There's been a time or two that the committee did some things that I wasn't entirely in agreement with, but that's what I take back to the Trauma Commission, and because that's what this group is here for. So I'll certainly try to answer any questions. If they're really tough, I'll give them the lead. Okay, thank you. So I think the first thing is the approval of the minutes. Y'all got a copy electronically. And I would entertain either a motion to approve or amend.
I'll make a motion to approve.
Motion to, motion. Okay.
I'll
I have a motion.
second.
I have a motion and a second to approve. Any discussion? All in favor of approval of minutes, aye. Aye. Any disagreement, same sign. Minutes are approved. Thank you. GTC update, Liz.
Good morning. So I'm Liz Atkins, for those who I just met this morning for the first time. Official chief cat herder for one dentist, actually. Primary role. Just a few updates from the commission. One is that Katie and I worked with the Department of Treasury as well as the DPH finance colleagues to get Georgia Fund 1 set up, which is our trauma trust fund now, and all of our super speeder monies and fireworks excise tax go to that Fund 1. It's been a pretty steep learning curve, would you say, Katie? We're trying to figure out what I think our budgeting processes look, what they're going to look like now moving forward. We are getting more of our money up front, so we won't have that sort of $8 million true up mid-year. So this year was the first year that we got the bulk of the monies up front, and you guys realized that with the money that you had for EMS distribution for your upfront equipment grants, that we haven't started that process with yet, but and also the education funding. So much more to come on that as we know. I mentioned last time the level 3 and level 4 readiness cost survey, the first one that we've ever done. First one that we know of in the country that's done. Dr. Ashley presented that last month at the American Association for the Surgery of Trauma. It was very well received. This information is just not out there. So it's going to go down as one of those sort of hallmark papers that we've received a lot of correspondence from folks around the country wanting to know, how did you do this? We want to see your survey tool. We're actually working with Trauma Center Association of America to pilot our level 1 and level 2 survey with a limited number of centers across the country, just to validate and see what they get. We haven't done a level 1 and 2 survey since about 2018, 2019. So with changes from the pandemic, et cetera, it'll be really interesting to see what they get from that. So I'm working with them just to make sure that the processes are consistent, so we can have a real true apples to apples comparison of what Georgia costs look like for that, and then what we get from the national perspective. Two other really big things. One is, I mentioned last time, our colleagues from the Pennsylvania Trauma Systems Foundation deployed 2 teams to do consult visits to 5 of our level 4 centers the week of October 10th. The 5 centers that were visited were Polk, Effingham, Meadows, Emmanuel, and Morgan. So far, the feedback has been tremendous, that folks learned a lot from those. You can speak to that. I think you were there at your, at your visit. I think the teams found that the centers welcomed them with open arms. They were very interested in learning how they could do things differently. And it almost like got me a little choked up when I got a couple of text messages from folks just thanking the commission for their support for this. They'd never had anything like that. And it really meant a lot to them. They're in these often austere environments without a lot of resources. They don't know how to do it well, and they want to learn how to do it better. So that, I think, is probably the most promising thing about it, is that we want to figure out how do we really call attention to this level 4 situation and really elevate it to the level that it should be. It's that first facility that a lot of patients don't have access to anything higher than that. So we have to figure out how to really bolster up the care at the level 4s to make it what it should be, so that patients can actually survive some of these things that they'll. It's going to take them a while to get to definitive care. So at the November 17th commission meeting coming up, the group from Pennsylvania will be present to discuss in aggregate, not individual center information, but an aggregate summary of strengths, opportunities, and recommendations from those visits. And with that will be the chairman of their board, who's also an emergency medicine physician, who was one of the teams that came to survey the centers. And if you are in regions 1, 2, 4, 6, 9, and probably 8, you should come to that meeting, because level 4s are important to you because they're in your regions. 8, you don't have any, but you probably need some. So we need to really figure out what that looks like. So if you can't come in person, they'll be on our website. There'll be a link to the Zoom meeting, and we're putting that group first up because they have to catch flights to be able to get back to PA. So we've allowed about 90 minutes. Their presentation will be about an hour. We've also invited trauma medical directors, program managers, and administrators from the level 4s, because we want there to be a dialogue about how that went. So very excited about that. One of our big focus areas as well. The November 17th meeting happens to coincide with World Health Day. So it is that November meeting is the annual meeting for the Georgia Trauma Commission, but it's really taken on a world focus now. We'll also have presentations from the Georgia Rural Health Innovation Center. Glenda will be there to talk, as well as Nita Hand, who many of you know from her long time in EMS from the State Office of Rural Health. And we have several initiatives going on. Courtney, I'm assuming you'd like to touch on the March pause piece before I finish. And then you've heard me talk now for about a year on this American College of Surgeons rural focused visit. So a lot of you have been around for a long time, and you remember that in 2009 we had the American College of Surgeons come do a trauma system consult visit, and we were working to get them to come do a rural focused visit. But because they need to kind of understand how rural interacts with the urban tertiary care centers and environment, it really morphed into now we're doing another full system assessment with a rural focus. So what this will look like is day 1 will be, and it's going to be, pardon me, let me open my calendar. I believe it's January 9th, 10th and 11th. January 9th will be at Lake Blackshear all day. That will be the full system day. Several of you have been on invited stakeholder lists. That meeting will be, a stakeholder meeting will be open for anybody to listen in on, but we are going to have to cap the in-person presence a little bit. So we have a very large stakeholder group. I'm working collaboratively with our colleagues, Kelly, Michael, and Renee from Office of EMS and Trauma to prepare the pre-review questionnaire for that. And they've also selected several of the stakeholder groups from some of the EMS entities that they want to talk with. Then once we get the full, there'll be a team of about 9 site surveyors, and their from all over the country. I had the opportunity when I was in San Diego over the weekend for the American College of Surgeons National Committee on Trauma meeting. I got to meet the chairman of the rural committee there, and he's coming, so he's
Where's he
great.
from?
Somewhere north Midwest. They're gonna send me a whole list and biographies for each of the surveyors, so we'll know where everybody's from. But he's practicing orally and just a great guy, has done a lot of these sort of visits for them. So day 2 will be a half a day, and that will be the sort of southern Georgia rural focused visit, still at the venue at Lake Blackshear and Cordele. And then, because we know we have a lot of rural areas in North Georgia, Wednesday, the 11th, will be in Cartersville to have folks from the rural areas there come. So we're essentially saying like regions 1, 2, 3, 4, and 10, Cartersville, regions 5 through 9, Cordele. Cordele day 2, Cartersville day 3. Day 1 is the full system thing. It'll still be all 9 surveyors for all 3 days. We've given them sort of 5 focus areas to look at for the rural focused visit. One of those is something near and dear to every one of your hearts here, and that is transportation. How do we move patients throughout the system? We have limited resources, trucks, staff, everything that complicates that problem. And then another big one is sort of provider competency. How do we, in these times when you can't send people to classes, how do we ensure everybody can do the skills that they're supposed to be able to do, that sort of thing. Everything from the pre-hospital providers on through to the emergency room docs. They have to be able to place chest tubes and do life-saving procedures. So much more that we will share with you once we have more information about that. And I think that's it. Corey, did you want to talk about March Cross?
Well, it's down at Old Business, I think, so.
Oh, okay.
The Old Business. I would tell you something. If you're involved in EMS, then anywhere in the state, you got to be there on the 9th. You ought to be there on the 9th because that's the whole system day. That doesn't mean you're going to get to talk, but you can certainly listen. And if you listen and if you give us some feedback, we'll assure you that we will get it to the evaluators. If you're from rural Georgia, on the 10th and 11th, you need to either be at Cordele or at Cartersville. Folks, it's never been done before. American College of Surgeons have never done this before. This is the first time, and we've asked for them to come in and look at our system and how we get things done or not. We have some issues with transportation. And I'll talk a little bit towards the end about some meetings I've gone to about that, but I don't get too much into that right now. But I would ask you to take those dates back to your council and tell folks that those are days that you ought to go to that. Somebody from your council. I'd encourage every one of you to be there because I think it's important for us to have our voice heard, and so that when we get the recommendations back from them, it'll be meaningful. Is that reasonable?
Courtney and Liz, I know you said that y'all had asked them to focus on certain areas. Does anybody fill out like a pre-assessment tool so they know generally the climate of the state?
Yes,
Okay.
thank you for mentioning that. Renee and I are working on that now. They just revised, I just checked the website and I don't see it yet, but they revised the trauma system standards book that they have out. I actually got to work on one of the work groups for that. And with that, they revised the pre-review questionnaire. So it asks for a lot of policies. It wants to see motions and pass rates of your advisory committees and things like that. So it's a lot more in depth than it used to be. And we'll be working on that. We'll have to send that in at least 30 days in advance of the visit. And then they will use that to sort of guide their line of questioning. For the rural focused visit, since they've not done it before, they don't really have a specific a questionnaire for that. It's mostly that they want to, meet with the folks in the trenches to sort of talk about that. But the 5 things I found, EMS transportation system provider, clinical, procedural competency, initial and ongoing, financial sustainability, so recruitment and retention of staff, providers, and trauma centers in the system. And then a dissociation between rural Georgia and urban Georgia, like how can we get the two, sort of the new phrase that we're using in the administrators group is rural driven, urban supported. So, I think that is a little bit better received. And then the last thing is the lack of outcomes data and process measures to guide effectiveness of intervention. So we don't have a lot of access to measurement data to say like, you can't measure it, right? You can't prove it. So luckily Gina has just launched our risk adjusted benchmarking database and actually has her fingers on data already. So, and the commission will be signing a resolution about how that works so that we can make sure that all of that is protected in the peer environment so that we can actually do meaningful case reviews and get to the bottom of some of the issues.
So I would tell you that I participated in the Pennsylvania group when they came to our hospital. And it was a good day. I mean, they spent some time. We had to fill out a pre-visit review and send to them so they knew us when they got there. But our whole staff was very appreciative of the work they did. And we were lucky we got the chairman of the board came down to deal with us, the physician that chairs that group. So 3 things I know of that's going on that are assessment tools for our state right now. One was that specifically looked at level 4 trauma centers. Michael and his staff have gone through a NHTSA review just a month or so ago, Michael. So they're waiting on that information to come back. And then the third piece of this puzzle is the American College of Surgeons review, which will be in January. And I don't get giddy anymore. Those hormones have gone away. But I think we really have an opportunity towards the first of the summer to start putting 3 pieces of a puzzle together and actually getting a good look at how we perform. And I think that will give us some really good energy to start making some changes that we need to.
Of the trauma centers in Georgia, how many of them are ACS verified?
There's about 9 of them now, I think, when I looked at our.
Is it mostly the 1s and 2s that are doing that?
Yeah, there's 1 3 that's verified now, but all of the 3s at least have their consultative visits scheduled. And we had to, the ACS got a little bit behind during COVID, so they're required to be ACS verified by June 30th, 2025. The level 1s and 2s are coming up this June 30th.
Is that a requirement by the Trauma Commission
Yes.
to
be
continue
funded.
funding?
Mhm.
Okay. And what was the deadline for the 3s?
2025.
Okay.
But we may have to push that out because some of them aren't having their consult visits until end of 2023, which would mean they'd have to have an 18-month turnaround from consult to getting verified. And I'm not really sure that's doable. And this is meant to improve quality, not be punitive. So we want to make sure we're setting them up for success.
I'm gonna back up for just any questions about any of that. I'm gonna back up for just a second for the new members because I thought of something that y'all might want to know. The Trauma Commission gets money from 2 buckets. One is the Super Speeder Fund and the other is the Fireworks Grant or Fireworks Act. So Super Speeder, if y'all kind enough to drive home over 20 miles an hour over the limit and they write you up, then you're considered a super speeder. Okay, you get an award. They allow you to pay $200, I think, back into the system for us. And that brings in the lion's share of the Trauma Commission funding. The other piece, Jeff Mullis, a couple of years ago, sponsored legislation for fireworks to be legal in Georgia. And the taxes on that is split between the fire community and the EMS, or the Trauma Commission, not EMS, the Trauma Commission. So those 2 buckets are our funding for the Trauma Commission. When it first started, the Trauma Commission, Dr. Ashley and I had some conversations, and essentially what it is, that the split was 80% to the hospitals and physicians, 20% to EMS. So that had always been exactly accurate. There's been a year or two, we got a little bit more than 20%, year or two, we got a little bit less. What we have done with the trauma commission is we take the bucket of money, we take off the top the cost of doing business, to hire Liz and Gabby and Katie and Gina and all the work that they do. And then when that bucket is taken care of, the remainder, we try to split 80-20. This group has been charged with giving advice on how to spend that 20%. Now, the lion's share of the money goes to two buckets, well, three buckets, I guess. Education, and we have a contract with GEMA, and they manage essentially the education piece. Every year, they bring a proposal to us, and we look at the proposal. In the last meeting, it was interesting, but we came out with it. I think everybody left happy. I did. Because we changed it a little bit to do more initial education, because we perceive that as a huge need. So that's one bucket, that education bucket. Another big bucket is ABLS equipment. Most of you have ABLS units, automatic vehicle locator systems, in your ambulances. If you have them sponsored by the Trauma Commission, and Tim helps you look out after that, then we pay not only for the equipment, but we pay the maintenance and the airtime for them. So that's a pretty good chunk of money. The other chunk of money we're going to talk about today, and that's the equipment grant. And there are a few other little things that we do, but I think, y'all correct me if I'm wrong, those are the big buckets that we talk about. So 2 out of 3 of those buckets have been adjudicated for this budget year. And today we hope to get the last one, which is the equipment grant talked about. Any questions about that? Okay. And Jim, you ready?
So this work here?
Yeah, that's good with me.
Okay, so the key thing I think that characterizes quarter, it's called shortages. Everybody got everything I deal with that this last quarter in ADLS. We had a shortage of chips. We have therefore a shortage of equipment, which meant that when we ordered equipment, it took forever to get here by way of China and Israel and Ireland and wherever it had to come. We also had a shortage of personnel in the agencies that everybody was talking about. And so even when the equipment would arrive, sometimes it's not getting installed, whatever. And then the other side was there was a shortage of ambulances because, EMTs drive them into ditches and people run into them in the front of the hospital and all kinds of things like that. And so we're short of ambulances. No news to any of you, but that's been a confusing sort of thing with ADLS in this quarter as well in terms of getting things going. But that being said, give me another slide. We did do a number of things in this report, which you all have a copy of. It just lays out sort of some of the deliverables, different kinds of activities that are involved with managing through all of that. You can see it goes everywhere from activating SINs to adding units onto our counties, onto the ABLS, and doing troubleshooting when things don't work. Getting people connected with ITS or Sierra Wireless in order to get the support that they need. It's interesting, herding cats is a useful euphemism. We have so many agencies and so many units out there, and things go wrong with them, and everybody's relatively independent, but getting help when the agencies need it is, an EMS agency, especially a small EMS agency, is busy doing EMS. And so remembering who to call when something breaks, which hasn't broken for 2 years, is always an issue. So that's my job, is to sort of be in the middle of that and helping facilitate that communication and keeping things on, which means that I'm looking over people's shoulder a lot in terms of what they're actually got online and are doing. And also answering phone calls and texts and emails when they're saying, it don't work. And trying to get the support to support that. It also means as you bring new leaders on board and in the agencies that spending time with them, not usually a lot of time at any one time, but maybe several different times, sort of getting them on board with what they can do with the system and how they can use it to benefit the agency and the overall system. And so I do a lot of those sort of things. The other thing we do is keep track of the unit usage. And so by region, we're looking at these agencies out there. In each region, we look at the number of active units, the number of total units that we're providing out there, and what's the percentage that's up to speed. And there's 1,211 active units in the first quarter on average, out of 1,420 that are out there. The 1,420 are not all funded by the Trauma Commission. Majority of them are, but some of them are funded by the agencies themselves, by their own equipment. So, but if you're looking at the overall system of how many ambulances are out, 911 ambulances are out there that have AVLS systems that are on the Georgia system, you're looking at 1,211 on average active out of 1,420 that are out there and running about 85% upgrade on the fleet overall. We have some counties that don't have AVLS. In the Cherokee County, they have their own system, have from the very beginning. Camden County had the system originally and then stopped using it because they were dealing with something from a hospital in Jacksonville that provided for them. But with a new director down there, we're in discussions with him. He's very supportive of it. He's working with his county commission and the folks there to get that set up. And we've got Sierra Wireless talking with them, going through their use case. Chattahoochee and Muskogee, we're in some discussions with them. This goes along. DeKalb, we've got a meeting with AMR and CAB Fire that's been, unfortunately, due to the shortages and sort of thing, it's been pushed back. Hopefully in the next week or two, we'll pull that one together. Gwinnett County has their own system. Long County has their own system, but we've opened some discussions there, and we'll see what happens with that as well. Lumpkin County, the county purchased a cradle point system from FirstNet. FirstNet was actually not just selling cellular service, but selling something else as well, and they did that. So we have a quick reference guide that we put together so that for anyone who is interested in the system and or new leaders coming on board, that it gives them sort of a get up to speed on the key things that they need to know. And that last was updated in 2021, but it's still current as it stands. And so that's one of the deliverables that I'm responsible for as well. Then we have airtime. One of the things that we fund through the subcommittee is the airtime. You see, we have Verizon Wireless, AT&T, T-Mobile, and Southern Link, the 1,253 units that we're paying for out there on each of those agencies. And it's unlimited coverage from each of them. In the past, we've rotated those as people have needed them, and each agency can choose which one they want when they come online. Now that basically most of the agencies are online, we're going to have an open enrollment period at the beginning of, or the middle of each year, basically the beginning of each year, of 2 months when people can make choices if they want to change from one to the other agency for their service.
actually, Tim, we voted 3 months.
3 months.
And that starts December 1st
Yeah.
and ends February 28th. So go back to your regions and tell them if they want to change vendors, they've got to do it between December 1st and February 28th. If you
And
call
I would-
February 29th, well, that might not
Yeah.
happen this year, but if you call the next day, then you get circled back to December 1 of next year.
Are we sending, I know we're communicating, but are we sending something out?
Yeah,
to
I
agencies?
have an email that is, we've been staffing it around, got it, I think, worded up and it's ready to go. So in the next week or so, it will go out to everybody. We're set, ready to go with that.
Hey, Tim, I'm not asking you to do this. I'm just curious. On the breakdown Verizon, AT&T, T-Mobile, Southern Link, if you got a map of where they are they just people's choice? Because I know some areas have talked about this provider is not as strong as that provider. And I didn't know now that you, I mean, I'm not amazed. I'm surprised that Southern Link is almost equal to Verizon. So I'm just wondering if it's coverage or, you know?
It is covered.
It was?
There's a lot of coverage. I haven't done the math. Actually, we could do that now.
It just, to me, it'd be interesting to see. That way, if a new director came in or was having issues, they could look at it and you could say, well, you're right in the middle of an area that's covered great by Southern Link. You've got Verizon, that might be part of your issue.
Right.
Or whatever.
You also have, and correct me if I'm wrong, because I think we did this for a while, and we may still have this in place. With the NG90s, there's a place for 2 cars.
Yes.
2 or 3 cars. Our department actually put a second with another provider in there
Right,
so that we maintain the coverage better,
right.
because we use them pretty heavily.
And that is a possibility, and any agency can do that. We haven't done that on a system-wide basis, because we're only funding one card per unit. But it has been tried. And the truth is that it's, Southern Link has a footprint around its power grid situation. And if an agency is in that footprint, Southern Link has excellent LTE coverage. In the metro area, everybody has good coverage. So T-Mobile has been in the mix and inroads in the metro area because of other kinds of things that they can do. They do have preemption more like FirstNet than Verizon does, interestingly enough. Anyway, so those are the cases there. And then the new leader orientation videos, we got those still online. And the next slide, here you can see we had a budget of $100,000 for this fiscal year for MG90s, and we have been adding them and replacing them here. As you can see, $63,000 of that 100,000 has been committed. They haven't all been delivered yet. Some of them have, but a lot of them are still in the pipeline because of the supply chain shortages. Scroll that up a little bit.
So if you're looking at some of those numbers, and for you guys who are new, it seems a little strange. When we initially started, we bought a unit that is pretty much gone dinosaur on us. And as we have funding for those services, we still have those old units, we're replacing them. If one fails, we try to replace it then, but Jim's done a good job trying to get us an evergreen solution to this.
Are we making sure that these, when I look at some of those numbers, that these are strictly going on ambulances?
Yeah, I think there's a little bit of wiggle room sometimes, I think, with depending on how the use case that an agency has in terms of using its paramedic vehicles, then its transport vehicles, and so on and so forth. But that's a minor one or two units here or there. there's not, they are going on ambulances, 911 ambulances.
Right.
There are some of the agencies that have bought the equipment and put it on their fire units and put it on all kinds of other units as well. But what we're funding and what we're tracking are the 911 ambulances. And it looks like you see there, Toombs County, Terrell County, those are typical numbers. Walker County, that's actually Walker County and Dade County. Catholic Healthcare is a hospital up there, and they're taking over the coverage, 911 coverage for those two counties, and they're expanding that. They're going to also actually, on their own, add their Tennessee business on the same system as well. So that's what we have there. All right, and there's, yes.
Going out on what he said, has there been any discussion, something just popped in my mind? I know they're supposed to have unique identifier by county and what unit number it is that they call it in the county. Have we talked about maybe with that identifier, having them put the EMS VID number beside, in parentheses beside that identifier? That way you know what vehicle it's on from the state, because if the state ever wants to look at it, they're looking by VID numbers.
To my knowledge, we have not. Well, each ambulance has, like in Emmanuel County, if it pops up on the map, it might be 53 M3, which is the number we call it, but that makes some sense. I don't know how much work that would be to go in for all 1,400.
Well, the agencies would have to do it.
Yeah.
They would have to put the ID number in. I mean, it identifies each of the trucks that they're on. And when you're looking at things like when we're dealing with, like coastal, like when they're sending trucks down to evacuate trucks, or something like that, does that help at all at state operations? Yeah.
That's how we ID ours. We put what our call unit number is, and we put that 5-digit statement right behind it. So I can look at it and I know exactly what ambulance that is when I look at the dashboard.
When you look at two things, you look at the SOC issue, and then you also look at you're ensuring that it's on an ambulance. Kind of kills two birds with one stone.
When you look into that,
Yeah, because right now the convention is, they're all named, either they have the county number or they have the county name, and then they have the unit number, Med 1, Med 2, or Rescue 1, or whatever the case may be, is the way they're currently all named. The system will allow us to do what you're talking about, and either get those from the state or have each local agency do it. They can access.
But they would have to marry what unit number is what they call it.
Right.
With the VID.
And they can do that. For some agencies, just pros and cons. For some agencies, that'd be easy. They got IT people who can do that stuff real quick. For some other agencies, someone to get in there to do that is a different issue. So it just depends on the size and the computer technology capability of the agency. But we could do it if you wanted to do that. I think that's worth doing.
That would work for the state. That would work for the state to track them. Wouldn't be so good if you wanted to try to probably communicate them, because most directors don't know what they're.
Well, they'd have both. Now, not
Yeah, if they had both
exclusively
of them, that
one or
would be
the
bad.
other.
Yeah, we can
That'd be
just
good.
add it on.
Like for my unit, Henry R1, which is what we call it, and then this in parentheses beside the state VID.
That's a good idea.
We could
Yeah, I
do
don't
that.
think you're limited to how many characters you can put in.
Now, you can make it pretty.
It is, but we have
It's a
enough.
lot.
Yeah.
Yeah.
but the only thing that we start looking at the map, if you kept, and they're all on the map, you have a hard time figuring that out.
Yeah, I mean, we've done that from day one. Ours has whatever we call it. Like here in this county, there are 1,200 units, and then directly behind that is the state vehicle license number, 5-digit number. And then I think after that is the, not the IMEI, but the, I guess it's the serial number of that device.
Yeah.
Yeah, that's the next call.
That's in a separate field, so that's always there, so, yeah. Okay. And then, the last part of this is just a restatement of what, actually, go back to that other slide. Is the budget, that's where we stand. We budgeted $100,000 for equipment. As I said, there's 63,000 of it already. Annual maintenance, we budgeted 160, actually, we budgeted more than that. 167 we actually paid. And then you receive the monthly, what we spend on airtime. And then the grand total down there at the bottom. So that's what we're spending on the ADLS system as of right now. I think, based on what we've done, that we're $100,000 is going to squeak us into July. If you find any more money, raise my hand. But I think
Tim's always helped us do that.
I think it'll get us there as long as nobody has a major catastrophe out there. Okay.
Tim, the airtime looks to be pretty comparable between the providers.
Yeah,
Is it?
it's sort of balanced out.
Okay. I mean, cost wise per unit,
Yes.
basically.
Yeah, the cost per unit is the same for 3 of the agencies, basically, and then T-Mobile's $10 a unit cheaper than everybody else. So if you have any ability to twist arms at GTA, you can get the Georgia Technology Association to push on the other carriers to get a better price. That would be good for us, right? Okay, and then the next, I'm not going to go through all of these. You all have a copy of this. What I've done is I've gone through, I have every region and every agency and every unit laid out in terms of what units are assigned, how many units are assigned to the agency, how many are online, how many are offline, and it's all summarized up at the top, and then it's broken down unit by unit all the way down through several pages of this. We don't have time whatever to go through that, but if you're interested in looking in your region or your agency and seeing what it is, or seeing it overall, there it is. Everyone by.
And where is that located?
By serial number. You had, it's all of you, it's sent to all of you. And I do it, I prepare each quarter for this report. I wish I had it bottom, but
You will be consistent.
I don't. Okay,
So,
any other questions?
so for those new members and probably some old members, when we bought these devices, the initial monies came from GMA. Okay, we got grants for I think 3 years, Trauma Commission put some money in it, but GMA was buying these things with the idea of being able to identify where the ambulances were in a disaster situation. And Sam talked about the evacuation of the coast. So at any point, the state office of EMS can pull up on the map and see where every ambulance is in the state and whether it's moving or not, or where it's at. And that's to Sam's point, is if they see 53 M3, I guess they could have a chart that says that may be just as good as figuring out a VID. I don't know, but we need to, I think that's a pretty good idea to look at. The other thing that we did, there was everything we've done at different points that had some controversy. This was a little bit more. Initially, the governor's office wanted us to make this data public so that anybody could go online and see where your ambulances were. And I met with the governor's people, and we didn't agree to do that. And so what we agreed to do was the data is stored for 2 weeks. So where your ambulance went, you can go back and look for 2 weeks. All right. After that, the data goes away. And the rationale for that was that people didn't want other people to see their data and concerns about where their trucks went. It was a proprietary thing. They were concerned about business models and this sort of thing. So that I don't disagree with that, because The other point somebody made was, and that this is what probably carried the day, do you really want the plaintiff's attorney to be able to go in and look at your truck where it was when that ambulance call came in, and did they make the wrong turn or whatever? So it's a 2-week window. After 2 weeks, the data goes away. The disadvantage of that is that if we're looking at a systems and looking at transportation for critical patients, and people are saying, well, there's no ambulances available, it'd be nice to be able to find out why. And I'm not today fixing to tell you I'm interested in changing the system. But as we move forward with what Liz is working on, with our data being able to be protected as far as peer review, so the plaintiff's attorney can't go and look at how fast your ambulance was going or not, or if they made a wrong turn or not. One day, I think it would be very helpful if we can, on a system-wide basis, find out where ambulances are. Theoretically, we could combine that with the GEMSIS data on trips and times, and somebody who is very, very astute with computer systems could help us design a more efficient, effective system. Don't know that, but that's kind of a long-term goal in the back of my head. I will never push that as long as all that information is discoverable, because I think whether we like it or not, that is a huge issue. So as you go forward and think about it, consider that. Because
That's very possible to do from a technology perspective. There's tremendous data about ambulance usage across the whole state. The other thing I would share with you, just FYI, and that is in the, I don't know how many years it's been now that we've been doing this, 10 years, whatever. As I looked at this and dealt with things along the way and helped agencies and stuff, I've never yet had a situation where anybody has come up where somebody is charging and asking for a Freedom of Information or Records Act in order to get the information. But I've had 2 cases where agencies have come to me and asked me to help them get some data in order to determine and prove where their ambulance was and so on and so forth, which in fact defended their case. So it's worked. The only 2 cases that I've had in the 10 years or whatever have been to the benefit of the EMS agency at the request of the EMS agency, not from anyone outside. We haven't had any. I don't talk outside.
any questions for Tim?
Haven't times changed?
I'm sorry.
Haven't times changed? Before, people were worried about people seeing where they were getting their calls from. Now it's, oh, you want to run some of my calls? Come on.
There is that.
Excellent point. Excellent point.
All right, thank you.
Thanks, man.
But we will always, I assume we will, as the system is designed today, we will always run into those imaginary lines called county borders. And the politics of that can be daunting. And I certainly don't want to, I'm not going to that can of worms today. Leftover maintenance funds, do we need to address that?
No, there isn't any remaining maintenance funds. So we budgeted more than what actual maintenance costs were, and we did not. It was 167,620, but we did pull some from AFY 2022 remaining EMS equipment grant funds to pay for some of that maintenance. So there is about $34,000 that is out there remaining that we have not allocated.
So do we need to do that today? Do what?
That would be great.
We just flip it over new units.
That would be my suggestion.
So question to that is, Tim, can you get new units? I mean, I know we allocate this money and it has to be spent in a certain time frame. Now, I got stuff I've been waiting on for 6 months.
Yeah, we're getting them. They're about 10 to 12 weeks from order at this point. So that's what but the supply chain is just a little getting a little faster and it's a lot forward than it was. So we can spend it.
I'll make the motion that the money be utilized to purchase new replacement units,
What was the total amount again?
30,000.
$34,884.
$34,884.
Tim, what's a unit cost now?
$2,000.
Say 10 to 15. I second it.
So I have a motion and a second that to use the additional, not additional, I guess it's residual or leftover money of $34,884, I believe, to purchase additional AVLS units. Motion is second. Any discussion, any questions? Any disagreement, same sign. Motion carries. Thank you. Jim's update. Kim, are you or Kathy online? I'm sorry.
They're getting ready for the conference, so I didn't know if they were gonna be able to hear.
Yeah, so there's a rumor that they're working.
They're probably headed to that.
I know they were going to Jekyll today because they got pre-cons cranking up this weekend and for the session. I will tell you that, and I'll talk a little bit more about it in a few minutes, but I'm on the governor appointed me to the Healthcare Workforce Commission. And we met Tuesday down at Albany, and Kim and Chad came and did a talk. And they were very impressed with the courses that are being done with the Trauma Commission dollars, and particularly the number of contact hours that we touch as far as continuing education. Quite frankly, most of those folks had no clue about some of the training that's out there. So they did a good talk, and it's quite interesting. They were the last on the agenda, and they're supposed to end at 5, and they didn't get to talk till like 5:15. So you would have thought that as soon as they were over, everybody leave. But there were more questions asked about EMS than the total of all the questions asked about any of the other agencies. Having said that, most of the hospital people knew a little bit about nursing, and most of the nursing knew a little bit about nursing, and a lot of that other was physician and nursing and mid-level discussions. So, but it was a good thing, and they are on track with their education for the year. Any questions about that or comments? EMS funding. So I don't know that we need to dig into that today. Anybody got any questions about the 23 monies? So let me jump down and the equipment grant. So we've had several discussions about it, and I've had some frustration levels about the equipment grant and how we do it. And I know last time I talked about setting up some smaller committees to look at it. I didn't do that. We'll discuss it as a whole group. We have a pot of money out there. I'm sure about how much. Katie, could you tell me? $1,165,031. So in the past, what we've done is put out the equipment grant and had people apply. And we vetted them to a certain extent. And then we took the number of ambulances that applied and divided it into that number. And that was the base amount. And then if you have 5 ambulances, that you multiply 5 times that base amount, and that was the amount of your grant. Anybody not clear on that? My hang up has come with identifying, because what we have done is try to target 911 ambulances, 911 transport vehicles. And it gets a little flaky or a little fuzzy to me in some of the areas that have 911 services that do a good bit of general transport. So there's several of them that I think do a good job of separating their 911 trucks away from their general transport. Some not so much. I've talked to several of the state regional guys. I said, can you separate them? They said, no, not legitimately or legally, because it's a 911 agency. And because Georgia licensed all ambulances as an ambulance, we can't go up and say that's a 911 truck and that's not. There's really no way to do that. I looked at the concept of this. If it's a contracted agency, could you go and say, okay, the contract says you have 9 ambulances on contract and we'll only fund 9. I don't know of too many agencies today that have general transports that are not pulling some of their general transports into 911 service on a fairly routine basis. Anybody disagree with me? So I come down to this. We can do it the way we've done it in the past and accept that there may be some gray areas there and live with that. Or we can try to figure out a way to slice that pie down to get to an exact number. There are some different ways to do it. I don't know if it's agreement or disagreement. I talked to one person and said, Courtney, why don't you just say if you got 10 911 trucks, about 40 trucks, then you 80% or 50, you multiply 10 times 1.5. You know, I mean, we could come up with something like that. I don't know how that would work. I really don't. The other thing that I gave some thought to, and I've talked to some folks about a competitive grant. So we got $1.6 million or whatever we got. It's not that much, but we got that many dollars. Then people apply for competitive grant. I like that idea, but then it gets very difficult to come up with a scoring process and a validation process. You know, who gets the money. So I'm all ears now if y'all have got some different ideas. Yes.
Well, I will say the only problem I have with a competitive grant is that works great for larger services that have the ability to have people that are well versed in writing grants and all. But when you look at smaller services that don't have those resources and all, who writes their grants? Who's going to, and how is a small 2-person administrative, as far as administration service in South Georgia, going to be able to be prepared to write a grant to match up against an urban EMS service in Metro?
Well, I get your point, Sam, but at least in my mind, that the grant, you know, just like the equipment grants on one page.
I'm afraid that disenfranchises. That would be my only fear. It would disenfranchise the smaller 911 services that really need money.
Yeah, I agree with Sam on that. I mean, the purpose of the grant is to help these small rural communities purchase these items that otherwise they wouldn't be able to do. And I think if you do a competitive grant, that's going to hinder their ability to do that.
And I'd rather do something that benefits all of the providers, not just when you put it in a grant format. Now you're gonna have just whatever number of grants you accept and then everybody else to exclude.
Hey, Courtney, if you look at the zone providers, because those are the ones that are grant to begin with, so that's the first cut. You think it's 10% that may have a
No,
concern or higher?
no, nowhere near that.
Lower?
4 or 5%.
Okay. So
So we might be straining at a net.
no, I wonder if it'd be better just to go to them and say, this is the intent of it. And we need you to, I don't remember the exact math, but I think one of the things you and I talked about a while back was like 1 reserve for every 5 frontline or something like that. So that works out to that rough number you had. Because there needs to be a reserve. I mean, I don't think anybody would argue if you're running 2 911 trucks, you can't do it with 2, you got to have at least 3, if not 4, whatever like that. And that plays into the AVLS and other stuff. But I wonder if we just go to those 4 or 5% and say, hey, there's a perception based on, because Kelly and Michael, correct me if I'm not mistaken, anybody can go into the LMS system and look and see how many ambulances a service has on their license. that are paid for, correct? I mean, that's a public knowledge type question.
I believe so.
Okay, so ABC Ambulance Service has 40, and they do general transport, as you call it, and 911, and they're covering a county with 50,000. They're probably not spending, they're not probably using 40 trucks on the street. Fair enough for that. So would it make sense to just go to those services and say, this should only be applied for your 911 plus reserves, and see if that accomplishes it?
Yeah, I think, you know, one of the things that, and I printed off and looked at the application letter and the affidavit. And I think what you hit on would be good in the initial letter and in the affidavit. It says the design of the thing is for trucks that are used for 911. And some of the services that I have in my mind their response times are terrible right now. They've got a lot of trucks. So you have to make the assumption that they got a lot of trucks without people on them, or they're just that dang busy. I don't know.
And I think we need to be careful on that one, because I think you could argue that every provider potentially this 911 may not have all their staff units up at any given time.
Yeah, I actually looked at trying to do a survey of how many you had at peak.
Right.
And then that's your peak number. Then we multiply the peak times 3.
I mean, I don't know what number you're thinking, but I bet if we all sat together and wrote down what services we're talking about, we probably get 99% of them on all of our lists, because I think we know the handfuls of numbers we're talking about. We're not talking about Bacon County, and we're not talking about Troutman County and places like that.
Well, we got a couple of counties, I think, that run one truck. You just need to know where those counties are, so you be the first wreck that day, and won't be the second wreck. Because obviously they don't have they don't have
You
a
agree?
hospital in that community either, so.
Oh, you can. Okay. Yeah, okay. Thank you.
So
You can look. I thought you could.
yeah,
I have all
You
of our
can pull them all
licensed
up.
vehicles pulled up.
Because I think it
I'm not
has,
logged into
I think it includes MFRs and
every
neonates too,
license-
right? Yeah.
Every licensed unit.
So-
MFR or brand name.
Is the funding just for 911? Have we looked at anything for like the interfacility trauma transfers, where these services are transporting these trauma patients from rural hospitals?
if they're not a 911 zone ambulance, we don't fund it. You make a great point, Alan. I don't know how to adjudicate that. I don't know how to figure that. We're gonna talk a little bit more about that in a minute or two. Because that's a legitimate issue and a legitimate need. But we've never done that in the past.
Right.
So I'm gonna make a suggestion to move this along. 'Cause what I would like for y'all to agree to is that we change the grant documents to specifically state the intent of the grant is for 911 zone ambulances. And that we, other than that, we continue on as we've done.
I think that's a great first step.
And
And I think the ones that you're thinking about, and maybe we could put a small little list together and look and see if they change and see if they go down.
Appoint a small committee if we have to.
Yeah.
moving Forward and get 3 members from here to look
Yes,
at the
ma'am.
ones that. No, that was all I was saying.
You said change the document of the intent is for 911 only.
That's correct.
You may want to rethink how to word it, because ambulances aren't zoned for 911 territories, the service is.
Yeah,
And so, and I think that's the problem, you've got a service that's zoned or designated or service delivery, and not all our vehicles are doing 911. Is that-
that's it. So, but we are funding based on ambulance numbers. That's how we get to the right-hand corner on the spreadsheet.
I think somebody can play on the words. If you do 911 zoned ambulances.
But it comes down with ADLS, it's really concrete, because we're not dividing dollars. You can't divide an MG90 into 2 trucks. So what happens is you've got some agencies that have got like 7 trucks. And they have a zone contract for 4 911 trucks. They run all 7 trucks. They rotate them in order for good fleet management, whatever, they rotate all 7 of those trucks. So that means if they don't have an ADLS and all 7 trucks, they get 3 trucks running 911 part of the time that don't have coverage. So what we have actually done in those few cases, and it is a very few, you know, is they're basically covered. Because we can't divide it any other way. And that's from the very beginning, we've sort of done it that way. So if you took the number of 911 lights, expected ambulances by the zone covers, it's not equal, it's not going to be exactly equal. It's going to be real close, but it's not exactly equal to the number of cars.
The rationale is a little bit different, I think. And the
Yeah.
rationale for the ADLSs was that if we have to evacuate the coast, guess what trucks are going to do it? A lot of the net trucks or general transport trucks are going to be doing that, and we need to keep up with them. Kelly, I understand your point. So we need to word it so that we call the number of ambulances that you designate for your 911. I don't think we're going to get the answer no matter what we do with this change. And it may be that we don't need an answer on this. It may be that what we're doing now is perfectly fine. And the reason I brought it up because I got beat up several phone calls about why in the world so-and-so get this, this, and this. I get those calls on a regular basis. Y'all may too, I don't know. So I just wanted to bring it to the group. So what I'm gonna try to do is entertain the motion that we change the application letter to reference the fact that we're looking to fund ambulances that are dedicated to the 911 zone. And that we continue other than that, just like we've done. Without a motion, we'll do it anyway.
I'll make a motion.
Dick makes the motion and Huey seconds. Have I confused everybody?
No,
Have I pissed off anybody? I got a Snicker bar.
I just want to buy it.
This is a 3-piece. I can buy it. Okay, any other discussion? All in favor be aye. Any opposition, same sign. Motion passes. Thank you all for that. The staff has been really good about getting this stuff done very quickly. And so I think you can go back to your councils and tell them in the next month or two, they will be getting documents about the grant and they will have a limited time to apply for the grant and to please do so. Immediate transport from non-trauma hospitals. Again, I don't have an answer for this. So I had the opportunity and the opportunity presented itself because last year at the leadership conference, some of you may have been there. There was in the legislature at the time a desire to have a study committee on healthcare workforce. It's going to be a legislative thing. It died because at that point they already had 40 members assigned and they knew that wouldn't work. But there was a conversation supposedly by the GHA people that EMS didn't need to be involved in that discussion. And so I called the rural health guy with GHA and he put me down at Anna Adams. She called me and we had a conversation. And I said, you know, we are trying from the Trauma Commission very hard to develop as good a trauma system as we can have in the state. So if you have a car crash in rural Georgia and they take you to a rural hospital and you can't get transported out, then there's not a whole, the environment may be a little bit better, but it's not a whole lot of difference bleeding to death in a hospital versus bleeding to death on the streets. And when that occurred, when this healthcare workforce got appointed, it's actually the GHA people asked for the governor to appoint me to that group. So I've been sitting on that group, learned a lot. But also that brought up the Rural Hospital Association. Georgia Hospital Association has a rural group and they meet. And so my boss was invited to do a talk on March Pause because our hospital has a grant and I had a section on EMS. And I will tell you, it's amazing what hospital people don't know about EMS. So one of the talks that I had about the concern we have on the trauma commission about people getting timely transportation to a level 1 or 2 center. And what I said, and then anybody wants my slides, I'll shoot them my slides. You have to send me a reminder, but I'll send out the slides. But the big thing I talked to them was about they need to have the discussion with EMS before the fact. And if all we're going to do is at the time when it's crucial and critical, is you're going to go beat up on the EMS people because they didn't do something, then that's not going to get resolve the problem. So if you want to resolve the problem, go see them, talk to them, tell them what the issues are, and have a discussion with them. I said, I'm not going to tell you that that's going to solve the problem, because if they don't have trucks, they just don't have trucks. You know? So a guy came up to me at break and said, you know, we had a guy in our ER the other day who car crash, he had a mangled leg, no blood supply. If we could have got him to a vascular surgeon quickly, his leg would have been intact. Didn't happen. Stayed in our ER a couple hours. And by the time he got to a vascular surgeon, they removed his leg. You know, I don't know how often that happens. I do not. But if it happens at all, that's unfortunate. And with the group yesterday, which was the workforce task force, Kim and Chad did a great talk. But I pointed out that we have that issue. Today, I don't know how often we have that issue. We are trying with the Trauma Commission and State Office of EMS to get some definitive data on what we call time to care, from the time the crash happened until the time they got to definitive care. Whether that's a level 4 center that you know shows them up, or that's a level 1 center that you know opens them up, spleen, 40 units of blood, whatever. So we're still trying to work through those processes. In the meantime, what's going on in rural Georgia, I think every day, where people need that transportation. They don't get it. So from my perspective, trauma is the issue. But if you're a rural hospital, trauma is one issue. Stroke is another issue. STEMIs are another issue about getting to definitive care. And I did part of that talk was about the fact that EMS was designed in 1966, even before Tom, with the white paper that all of us are familiar with, the death in the ditch. But if you go back and read that thing, some of the stuff that they thought we should do in 1966, we haven't done. But in 1966, and indeed, when I started, you know, when I started in 77, if you were in a car crash, you went to our hospital. If you had a stroke, you went to our hospital. If you had a heart attack, you went to our hospital. And there's where you stayed. There was no trauma center. There was no stroke center. There was no cath lab. It just didn't exist. You lived or died at a manual medical center. And I think most of you in rural Georgia who are old enough, that's what happened. But today, that's not the world. That's the way EMS was designed. That's the way county commissioners funded for the 911 truck to pick up a patient, take them to that hospital. Hospitals have changed. Systems of care have changed. EMS, not so much, at least in my world. So I think our challenge, my smart comment is it's time to redesign. And indeed, I see requests for proposals on a regular basis from county governments to start up an ambulance service. And if you read them, somewhere in there, it will say X number of ambulances need to stay in the county at all times. And I have friends who say, well, if we have to have 1 or 2 county ambulances in the county, or we don't go out to the county. And my comment to them has always been, and if that's your child in the ER bleeding to death, what you gonna do? And so far, none of them have said, well, I'll go watch you bleed to death. everyone have said, I'll take the last ambulance, I'll do whatever I got to take care of my child. So I don't know the answer. I mean, I've thought about it a whole bunch, but, you know, I don't run the EMS in Emmanuel County anymore, but the bottom line was if it was a stroke, if it was a STEMI, if it was a critical trauma, the last ambulance in the county, it didn't matter. They were going someplace to try to save their life. And I'm pretty well concerned about how we fix it.
Well, I think some of that gets into maybe back to licensure of the vehicles. Because in most elected officials' minds, that ambulance should be sitting here to run 911 calls and y'all can use, we see those other ambulances running up and down the road, y'all can use them to move these patients from hospital A to B. What they don't understand is those other ambulances they're seeing are usually dialysis transports. And those folks probably have very minimal experience in doing a blood pressure, much less taking care of a critical care patient. So I think that's where some of that comes into play.
Yes, sir.
Yeah, I guess I'm going to show my age. A lot of this originality was there were no boundaries. There were no such thing as a county line for EMS response.
Right.
Now, 30 plus years later, it's being put into contractual agreements. It's new.
And good point, because when I started, we'd run calls in Jefferson County, Johnson County, Truthland County all the time. But now, you know, for years, we had a good mutual aid agreement with other counties, but now you call them, they don't have the resources to send either. So part of it is a resource availability. You know, used to, I could do what we called an all call, and we would pay them 2 hours just to show up. And I'd end up with 10 or 12 people there for one trip. That killed the budget. Now you do an all call, you don't get the response at all. So the resources are part of it, no doubt. Yes, sir.
And so our agency, it is our policy, if the ER calls for a emergency transfer, for trauma, cath lab, whatever, we will take it. If they're not able to get any other provider, any other mode of transportation in a reasonable time frame at all. But that being said, on the other side of that, when you have the county where I live in, I think they run 3 or 4 trucks. And recently, my roommate was in a motorcycle wreck at night, and he called me to come get him because they could not get an ambulance to come get him. The county called, the local service called surrounding counties. The closest one was greater than like 35 to 40 minutes away on the other side of Newton County. Was the closest that they could get. So he was like, I'm not sitting here waiting for that. I said, no, you're not. I went and got him, and he qualified for trauma destination, quite frankly, under mechanism.
Yeah.
So I took him up to Piedmont Henry in my car. Fortunately, I had a little bit of pull there, and we didn't sit in the waiting room. But with that being said, for my county, which has a critical access hospital, if that hospital had called for a emergency transfer and had an ambulance to send them, and may not have even had one in the county at the time, depending on what type of patients they had, because that hospital can only take certain things.
Well, they can take anything. And that's,
But they're
they
not gonna be
can't
able to
take,
keep it.
they can't take care of it effectively. That,
They don't even have an L&D.
yeah.
So
So I don't have the answer. And part of this, I think we will look at when we have the ASC rule group, and And I have been on that planning group, and I've been very insistent that the transportation, inter-hospital transportation has to be one of the key focuses on how, on that look at. Because if you can't get that patient where they need to be, it's a time critical patient, then we as a system are failing. And I don't like being in that position. Let's see there. Any questions about that? Any comments, any ideas?
I think at some point in time, the hospitals have to have a skin in the game as well. They know that they're accepting these patients. I feel like at some point in time, you know, everybody relies on the EMS, and at some point in time, there comes a time when you can't do it. I think hospital managers and hospital systems, I think at some point in time, they have to have some added skin in the game to take care of their patients, to get their patients where their patients need to go.
So,
By contracts or whatever. You know?
and you know, Huey's point about, you know, the transport agencies that do that. And you've got two, I think, in Bullock, and we use them in manual on a fairly routine basis. But those guys are in business to make money, so they try to do as many scheduled transports as they can, because so they're oftentimes not available for that emergent transport. The other piece to the puzzle, Huey made a good point. And I made the point down at St. Simon's. I said, do you know who's in the back of your ambulance? And I told the hospital administrators, there's hospital administrator, CEO, and board members in that group. I said, an ambulance backs up to your door. You know the qualifications of the people in the backup. Do you know the equipment in the backup? Do you know if the equipment's been calibrated? I mean, at the end of the day, under the federal law, the way I understand it, that patient is a patient of that referring hospital until they get to the receiving hospital. And we've had patients that left our hospital on ventilators that 10 minutes later were back in our hospital because they ran out of oxygen or the ventilator broke, depending on which medic you listen to. Okay, so most critical patients, we absolutely try to send out with our staff because we know their capabilities.
Yeah, I don't know if I'd say they're in business to make money. I
Yeah.
think that's a fair assumption.
And there's
I
nothing
think
wrong with
it's-
that.
I think it's they're in business to stay in business.
Yeah.
I mean, everybody wants to make it out like it's a bad thing if you're a private service trying to stay in business.
Yeah, you got to.
I got people telling me all the time, I can tell people all day long that I made $15 million last year, but if it cost me 16 million to make 15 million, I didn't do too
At
good.
least now we know what you made last year.
No, I'm just throwing that
That's
out.
all right.
That was you personally, right?
I'm just saying, there's negative connotation for whatever reason. I don't know. I don't know anybody that's not in business to survive. And it's not they're in business to make money. They're in business to stay in business.
Yeah.
Whatever that entails.
If I said anything that gives you the indication I'm looking down on that, I am not. Fact is, without those people, we've been a hell of a lot worse shape than
Liz
we
and I
are
had
today.
this conversation. She said, we gotta do
Oh, I
something.
left the room for a minute. I just said
She says, we gotta do something about getting these patients transferred. And she said, maybe the trauma commission we can set up a study and we can put an ambulance. So I said, okay, fund an ambulance. Today's times, you want to do one 24/7, if it's 12-hour shifts, you're probably looking at about 700,000 a year. Where are you gonna put it? Every county in this state, you transfer.
And you're right.
And, and I said, you can do one ambulance, but I don't really think you're gonna learn a lot from it because the problem is so overwhelming, throwing money at it's not gonna fix it at this point,
Well, I think we need to figure out what the fix is
Right.
before we try to figure out how to fund it. I agree with that point. So again, the concept of the study we're trying to do to figure out, what is that time frame. And the other thing we talk about, count time to definitive care, one of the level 3 centers, correct me if I say this wrong, has done a study and they found out a lot of their time is not waiting on ambulances, is getting accepted by the referring trauma center or accepting trauma center. So there's all sorts of pieces of this puzzle that we've got to figure out.
It just significantly became even more difficult.
Oh, hell, yeah. Excuse my language.
There's three major drivers to this. One is the time to determination of disposition. That's not leaving the ED. That's when we said we need to go somewhere else. And then there's time to acceptance at another facility, and then time for transport, yeah.
I think, talking about the evolution of the EMS, Courtney, one thing that I've been screaming about for years, and I know everybody has and everybody deals with it, is there's so much expectation in the communities that EMS is not there to take them to a hospital. EMS is there to come to their house and give them the medical advice so they can save them a trip from going to the hospital and find out it's not needed. And until, as a society, we can address the abuse of EMS and what it's for and what it's not for. I tell people all the time, I've never seen an ambulance built that didn't have a stretcher in the back. So what does that tell me? They're designed to transport people. This thing about going out for God knows whatever reasons we go out for, a lot of areas it can be as high as 50% that we're just tying up ambulances needlessly than for what they're really designed to be for.
One of the other things in the 1966 paper says we need dispatch centers that can separate the need versus the want. Now, they didn't put it just exactly like that, but it took them about 2 pages to say what I just
Well, we
said.
saw what United Kingdom, they're having, in Britain, they're having major issues with EMS. They just came out with non-emergent requests for EMS. They're giving them 3-hour ETAs. And their E&D and their calls, whether it's life-threatening emergency, whether it's critical, whether it's urgent, whether it's, and they're breaking it down. Hey, okay, you expect an ambulance in about 3 hours.
We've actually started transferring Omega level and some Alpha level calls to nurses. And most of those actually stay there because they actually have the capability to set them up with a place to go and give them a lift ride there.
And I know some services are sending out a fly car, whatever term you want to use it, to evaluate those low acuity calls to see whether they need an ambulance or whether they can call them a cab or something.
I think the problem is a lot of different committees at the state level have discussed the problem. The problem is it's a multifaceted issue that's going to come across from that needs to be addressed, but no one committee is going to be able to do it because it's going to have to involve all the stakeholders.
One of the comments yesterday I found a little bit interesting was from or day before yesterday was from a hospital administrator, a large hospital. And he says, and we were talking about workforce shortages and the massive amount of money they're spending for nursing staffing because of the contracts. He said, we've raised our salaries for nurses. So we've got some of the nurses from the long-term care, the nursing homes have come to work for us. So now they're short-staffed. So they can't take patients. So now we got patients in our hospital that we're having to keep extra days because we can't send them to the nursing home, which means we're booking our patients in the ER. So it means the EMS can't offload patients to us. He said, his point was we're all in this together. It's a huge circle. So I was tickled that came about. So when we meet again, we'll start discussing ways that we can solve the issue. But anyway, if y'all will take this discussion back to your regions, because I'm real interested in hearing ideas from them about how we might be able to resolve it. All right.
I think it needs to go to committees at the state level, such as MSAC, the hospitals. Yeah, I think it needs to be a multi faceted stakeholder group that needs to make some recommendations and make some. That's the only way, because we've been talking about this longer than I've been on this committee.
On the federal level, they have the interagency on EMS. That's not the exact term for it, I forget. Federal interagency, which brings together HHS, DOD, everybody that touches EMS, they meet quarterly. One day I think would be nice to have something like that in Georgia, so that you find that certain state agencies don't even know the other state agencies exist because they're all within their sphere of influence. So, all right, I won't take up any more time on that. Learning management system update, I don't have any additional information on that. March pause, I'm gonna talk about that for a few minutes. For those of you who aren't here, March pause is the military acronym, and is what they use to train special forces and military folks on the initial care of trauma patients. All right. So the Trauma Commission looked for some time about, what Dr. Ashley was calling it 5 things to save a life. Liz and I both tripped over March pause about the same time, but it's the good thing about March pause is peer reviewed. They know, they've done studies on it. They know the acronym works. So what we have elected to do with the Trauma Commission was give Emmanuel Medical Center, my hospital, some money to develop a training program. So what we have done is work with level 3 and 4 subcommittee, and Dr. Patterson and Dr. Register, Dr. A's a ER doc, and Patterson and Register both surgeons, and all 3 work in rural areas. So we've been working on that. We have got a date set for the first class on November 9th. Ordered $54,000 worth of training materials that are starting to plug up my office right at the moment. So the first class on the 9th, we're kind of targeting who we're inviting to that. And it will be more of a development class, and it will be a class. After that, we will do a second class in Cordeal. And then hopefully the third, which will be the beta test, I guess, or the last draft, whatever you want to call it, in Thomasville. We have engaged the Mercer Rural Health Innovative Center, and Dr. Casey Bridges is working on our PowerPoints and slide presentations that we have developed with that group. And we hope that it will be ready for prime time spring of next year. It will be a requirement for the level 4 centers to have that class. So the idea of the class is that I'll tell you my story. I stand in the ER talking to our ER manager one day, and one of my crews came by me. I was still the boss then. They didn't speak to me. They didn't bow down. They didn't kiss my butt. They didn't do anything. They just walked by. And they were carrying a patient on a stretcher. And I looked and said, "Is that a stroke?" She said, "Yeah." Okay. She and I continued our conversation. About 30 minutes later, they came back with blood tubes, and they and the nurse started labeling the blood tubes. And the nurse took them to the lab. Just a few minutes later, the patient came back into room 1. The telemedicine device was already hooked up. The neurosurgeon from AU was online. He saw the CT scan in his image because it had been transmitted. They called ahead. They gave the name and the last 4 of the social. They had the records pulled. So they knew the records, they had everything. And guess what? It was almost no conversation because everybody knew exactly what to do. Bang, bang, bang. In our hospital, trauma doesn't work that way. So the goal is to put the EMS people, the ER folks, and the physicians in the same room. And when we show the ER docs how to put in a chest tube, the medics will be in there too. Is the medic gonna put in a chest tube? Nope. But in our rural hospital, 20 minutes after the patient gets there, 30 minutes, when the chest tube's in, guess who's gonna take care of it for an hour and 20 minutes? That they need to know how it goes and how it works, and yeah, they do. So we've had some discussions about what all we teach who, and we're trying to work through it. And all ears, if you got some ideas about how to do things, I'd love to hear those.
Or ideas, whichever one.
Yeah, whichever one I say. Questions about that? You were sent a meeting calendar, and all the meetings are here. It's a set date. What I'd like is a motion to approve that calendar.
So moved. Second.
A motion and a second. Any discussion? All in favor, aye? Anything else y'all need to bring to this group? So for you new members, was it a lot of fun? Not so much. If there's nothing else that we need to discuss, I'll entertain a motion to go home.
Make that one. And the new members, I'll say, Courtney always takes you out on the first time you're here.
So there's a McDonald's right there, the next exit, stop there. Thank y'all so much. Meeting is adjourned.